Good evening, everyone, and a very warm welcome to this Bharat MD Foundation webinar on Duchenne Muscular Dystrophy. I am Rama, founder of Bharat MD Foundation. We are a parent advocacy organization for muscular dystrophy, working to support, educate, and empower families living with Duchenne and other neuromuscular conditions across India. About Bharat MD Foundation, over the years, we have been actively involved in awareness and education, patient support, advocacy, collaboration with hospitals. Today's session is a part of that effort to bring credible medical information directly to families. Before we begin, a quick disclaimer. The information shared in this webinar is for educational purpose only. It is not a substitute for professional medical advice. Please consult your treating physician for any decisions regarding diagnosis, treatment, or care of your child. Now, it is my privilege to introduce our experts for today. Our speaker, Dr. Stephen Chrzanowski, MD, Assistant Professor of Neurology and Pediatrician, University of Manchester Strand Medical School. He will be speaking on standard of care for both pediatric and adult patients, currently available clinical trials, and possible pathways for international families. Dr. Mohan Kumar T, Pediatrician, Chesapeake Pediatrics and Adolescent Associates. Dr. Mohan has been a strong advocate for our DMD community and will be guiding the discussion and Q&A. We are deeply grateful to both of you for supporting Bharat MD Foundation and our families. Dr. Mohan, now I hand over to you, sir. Thank you.
Hello, everybody. Sorry, I think I was just unmuted now. A pleasure being here. And again, Ramaji, thanks for that fantastic introduction. And I do welcome everybody to this little webinar. Again, as she had pointed out, it is only an education session. And we have the privilege of Dr. Stephen from UMass in Boston, helping us to guide us through this program. Saying all of that, I would like to say a couple of things. Again, I am a pediatrician in Salisbury, Maryland, on the Eastern Shore, and my son, who's 28, has DMD, and basically my expertise is in where as a father, as a pediatrician, I try to kind of garner as much as information as possible and try to help anybody who reaches out to us. On that note, Dr. Stephen, I would like you to introduce yourself, and then, if you can, and give us a good couple of words about your thoughts about it, and if you can go ahead.
Gladly. Thank you so much, guys, for the opportunity, the privilege to speak to you today. Thanks for the kind introduction. I'm Steve. It's really nice to meet everyone. I run our Duchenne program at the University of Massachusetts. We have a large program, over 300 people. We have a lot of international patients, actually, which might be relevant to this audience. I'm going to talk. I have a lot of slides. I'll be comfortable sharing them. I'll talk about the standard of care today, what kind of trials are coming out, and what I think the future looks like for this. So without further ado, I'm just going to jump in so we can be good with our time. Disclosures to acknowledge, I just have to say this at the beginning of every talk I give. So we'll talk about what Duchenne is to just make sure everyone's on the same page. We'll talk about what different treatments are currently available, and this is specific to the US, and I know that there's international differences, what is coming through the pipeline, and kind of some of the things I think questions families ought to ask for consideration to travel for care. So first, Duchenne. Duchenne muscular dystrophy is the most common X-linked recessive disorder that there is in children. It's caused by fundamentally missing or dysfunctional DMD gene, which makes the dystrophin protein, which is this large blue protein. We traditionally think of this as stabilizing the muscle cell membrane during contraction. So when we all exercise, we tear apart our muscle cell membranes, and dystrophin acts kind of as the rebar to keep that intact and keep it functional. When it's absent, there is disruptions to this membrane, and that leads to what we see in the disease. Inflammation is important to understand in DMD. Inflammation is actually kind of a good thing for the short term. It fights infections, promotes healing, removes damaged cells, restores normal function. But when it's unchecked, when it lasts too long, that's when there's harmful consequences and damage that occurs. And that's a lot of the autoimmune disorders that we see. So there's chronic tissue damage, weakened tissue and organ, in our case, that's muscle, increase the risk of disease. So that's all the autoimmune diseases, rheumatoid arthritis, cardiovascular disease, diabetes. Because of the injury to cells and tissue, it impairs function over time. And that's why we see the weakness. And also less appreciated, but it does affect mental health. So inflammation is important to, quench, to minimize, to control in DMD. Why is dystrophic muscle fragile? Well, as we were saying before, all of us injure our muscle all of the time, but normally in people that are unaffected by this disease, there is adequate repair and regeneration of the muscle. So we injure our muscle and it repairs. But in DMD, that muscle is more susceptible and more vulnerable to injury. And so the repair cannot keep up with the injury that there is, and it leads to the progressive disease that we see. This is just a snapshot of some microscope slides of what dystrophic muscle looks like. So we're looking at just general muscle. This is unaffected, and you can see it looks pretty structurally intact. And this is an antibody stain specifically for dystrophin, and you can see it surrounds the exterior perimeter of all of these cells. In DMD, there's ongoing cell death, which is myonecrosis, but there's also regeneration. And between the cells, there starts to be deposited fibrotic tissue, scar tissue, and fatty tissue. And you can see almost an entire absence of dystrophin protein being made. So that's what we see at the cellular level. And we know that this disease is progressive in nature. There is repair, but that extinguishes over time while the damage remains persistent. So what was formerly functional muscle early on in the disease course becomes fat, becomes scar tissue later in the disease course. And that's why people get weaker over time. The natural progression of the disease is such that people typically hit their peak function around the age 8 to 10, I would say. NSAA is the North Star Ambulatory Assessment. This is just a composite scale that we use to assess function in individuals. The maximum score is 34. Higher numbers are better. And so people get better and better and better until there is decline. And that's presently what we've seen. So we're trying to push this curve to the right so that the peak of function continues to be high throughout one's life. Heart. Cardiomyopathy is disease of the heart. And this is important because the heart is muscle. And early on in the disease course, there's normal function. And there may be subclinical disease, meaning that there's no symptoms of any heart problems. But if we look at a microscope, if we look with an EKG or picture imaging, ultrasound or MRI, we might see some differences in the heart. As boys get older, there is heart symptoms, fatigue, tiredness, swelling, and we start to see more of those signs and symptoms on imaging. And then that worsens over time. And so we have to be very aggressive with how we manage heart function. And what we're trying to say in this slide is looking, a little bit further about how the heart is affected in the disease. So we know fundamentally dystrophin is absent. It's missing in all muscle, which includes the heart. That fibrosis, that scar tissue starts to happen. And then certain parts of the heart, this is, if you look at like a cross section, a sideways cut of the heart, this is the left ventricle and the right ventricle. You can see that there's inflammation and scar tissue in the side wall of the heart. And so the question is, how can we prevent this from happening? Because with time, the heart starts to get swollen and doesn't contract as well. And it's not I mean this not in a negative way, but it's more of a when does the heart become affected? Because we see most of our individuals do have some kind of injury to the heart with time. So we need to prevent this and protect the heart as best we can. In addition to the heart, we also know that lung function does decline. And so what we're looking at on the vertical axis is the percent of the forced vital capacity. This is just how we measure lung function. And you can see that with age, it does decline. And that steroids, the red bars, seem to make it decline a little bit less than if no steroids are on board. And so this is another thing we have to consider is how do we protect the lungs and help prevent pneumonias and infections like that. One of the things that I don't think there's enough input in is the neuropsychiatric comorbidities of the disease. And what this is well, dystrophin's in the brain as well. It helps the cells migrate when boys are in mothers, when they're developing early on. And so the average IQ is a little bit lower, but it's a whole spectrum. I have individuals who are law school graduates and lawyers and scientists, and I have individuals who are more challenged and have trouble speaking and communicating. But there is a continuum of intellectual disabilities, neurodiversity, and differences like that, as you can see here. Life expectancy is what a lot of people are interested to talk about, and it's really inappropriate at the present time to say what I expect life expectancy to be, because we have so many new drugs, we have so many new therapies that it's not what D&D was even of 5 years ago, that I expect my individuals to live well into adulthood, to go to college if that's right for them, to have relationships, to have jobs, to have meaningful contribution to society. And that's not what DMD used to be. We're doing a lot better job about this. So that's the history of DMD. Excuse me, I'm fighting off a cold right now too. Let's talk about treatments. And this is a little bit America-centric, so I apologize. But I show our team with the intention of painting the picture that we need interdisciplinary care, that while I, as the neurologist up here, focus on the muscle side of things, it takes a whole team to take care of this population. That includes cardiology, orthopedics, pulmonary medicine, endocrine, GI and nutrition, palliative care, physical and occupational therapy. It takes a whole team to really take care of this population because it is quite a complex disease. And this is most of our team that we work with. When I think of treatment, we can break it down a couple of ways. Fundamentally, I think of 3 treatment classes. I think of something that restores dystrophin, either addressing the genetic mutation or the missing protein. I think of something that can reduce inflammation of the muscle, and so that's steroids. And I think of how can we protect the muscle better. And at the present time, that's something what we call a histone deacetylase inhibitor, HDAC inhibitor. You can also think of it at what target are you doing from the biological standpoint, the genetic mutation, the missing protein, the inappropriate inflammation that's happening, the muscle injury, or the fibrosis and fatty replacement. And I've bolded what is approved by our regulatory agencies in America, with not bolded the research options that seem to be coming through the pipeline. In America, this is the pipeline of what we have to work with. There's a number of exon skippers, teplirsen, golodirsen, vitilarsen, casimersen. There's a number of steroids with deflazacort, vamorolone. There's gene transfer, gene therapy. And then there's Javinostat, which is the muscle protector. And I put a question mark of what is coming through the pipeline because it seems quite promising of what else is happening in the future. And treatment should be a combination fundamentally. Excuse me. It should include, if possible, all 3 of those categories: muscle protection, dystrophin restoration, and inflammation mitigation. How we get there is a big question. At what sequence, at what timeline do we do each of these? None of us really have any specific ideas. And then clinical trials introduce a big variable because many of these therapies are both commercially approved, but also available by clinical trial. And this is a really one-on-one basis of how we manage this. So we'll talk about current treatments for the next couple of minutes. And first, we'll start with the steroids. Steroids work better than anything else. They're the cheapest and the most effective way to mitigate progression of disease, to improve function, and to prolong ambulation, protect the heart, the lungs, and overall survival. And this is just the graph all the way from 1989, is demonstrating that prednisone made strength higher by Jerry Mendel's group in Ohio. Deflazacort is almost like a newer version of prednisone. people walk longer when they're on deflazacort. So on the vertical axis is the probability of ambulation. On the horizontal axis is age. And so when people are on deflazacort over a large population, they walk longer than when they are on prednisone alone. And the big question is vamorolone. Sorry. The big question is vamorolone. This is the newest steroid that's available in the States. The studies that are out initially compared it just to placebo, meaning no steroid at all. And naturally, the time to stand and the time to walk run was better when on vamorolone, which is the blue, the light blue and the orange, versus placebo. That means not treated at all. But when you compare them to the combination of prednisone and deflazacort, there really is no difference. So this is what's called a forest plot. When the diamond is more to the right, it favors vamorolone. When it's more to the left, it favors glucocorticoid combined prednisone deflazacort. And when it overlaps the middle, it means that there's no difference. And so when looking at the time to stand, when looking at the height percentile, and when looking at the BMI, there's really no difference across the stages. And so it says that this is not insignificant, at least comparable to what currently exists. Antisense oligonucleotides, or exon skipping, is next. A little bit complicated, excuse me again, to understand to those who are not scientists, but I'll try to break it down real quick. The normal dogma is that we have DNA, which makes RNA, which makes protein. In Duchenne, the mutation is called out of frame. And so you see if there's a Duchenne mutation, you cannot connect these RNA molecules together, and you do not make dystrophin protein. And so exon skipping removes one of the RNA groups. So exon 51 is skipped here, and it restores the reading frame. It restores the connection between the RNA to make a truncated and a shortened dystrophin protein, but somewhat functional. So that's the premise of how it works. And we have a number of exon skipping drugs approved and then coming through the pipeline as well. The green ones are approved, and then all the yellows are different clinical trials. I'm going to focus later in the talk on these two because they seem the most promising. But this is mutation specific. So for this, it's important that we know what the mutation is so we can decide which treatment may benefit an individual. If they have a mutation that's not skippable, putting an exon skipping drug to that patient is not going to do anything. And this is the data, very briefly, of the exons that are skipped, 51, 53, and 45, and what the percent of dystrophin made, some of the outcomes that currently exist. Excuse me. So you can see it's really not that much dystrophin that's restored. We'll get into the second generation exon skippers later. Function is improved across the cohort. There's not much dystrophin restored, but function is improved, so that's a good thing. We will talk about gene replacement next. A lot of people get quite excited about gene therapy, gene replacement. And I just want to break this down a little bit. The goal of gene replacement is to deliver a shortened microdystrophin, a miniature version of the dystrophin gene, that's this, in an adeno-associated virus, that's a little vehicle, to a body to allow the body's muscle to make this shortened version of the dystrophin gene. So that's like Becker muscular dystrophy in a sense. The goal is to give a miniature version of the dystrophin gene. And at the present time, we have one gene therapy that's available in America, Duchenne dystrophy moxeparvovec. The commercial name's Elevidys. You have to have, it was approved in 2023, expanded in 2024. 2025, there was 2 deaths, and it was removed, indication was removed from non-ambulatory patients. And there's ongoing research if it can be potentially helpful in the non-ambulatory population. You got to meet a couple criteria. You cannot have antibodies to the viral vector because one will mount an immune response, and that's potentially life-threatening. You can't be actively sick. And you have to not have mutations in certain portions of the gene because that can also cause an immune response. The data at 3 years, is overall encouraging. So what is seen is North Star. First, we'll go through this. Higher numbers are better. And we know that disease does progress with time. So the North Star number is going to get worse at baseline with time. But in the purple bars, the treated group, it gets better, and then it gets less worse, if you will. But it's better than the external compared cohort. So this looked at just the natural history population of the disease and said that those treated at 3 years were doing better than those not treated. And that phenomenon stayed consistent in the walk-run time and the rise off of the floor time. That the time to walk 10 meters worsened in those not treated in the goldenrod color as compared to those treated in purple, in both the 10-meter walk run and the time to rise. So it did get worse in the Elevidus group. It worsened over time, but it worsened less than those untreated, if that makes sense. Gene therapy comes with a lot of risks, and I think it's really important to understand that. It's not an innocuous treatment. It does come with potential side effects and harm. And so individuals that are on gene therapy have to be on a souped up dose of steroids for about 2 months afterwards, oftentimes longer. There is very close monitoring of blood counts, of heart monitoring, and looking at the liver for several months there afterwards, because there are risks to gene therapy, and there were 2 deaths in 2025. So it shouldn't be minimized, and it shouldn't be just assumed that it's a perfectly harmless treatment. The last present therapy that we have available is called histone deacetylase inhibitor. This is quite complicated. I've done my best to try to break it down. There are these fibroadipogenic progenitor cells. These are like the stem cells of muscle. They can make either more muscle, they can make fat, or they can make scar tissue. And when this particular protein enzyme is overactive, which it is in dystrophic muscle, it makes scar tissue and fat tissue. So if we inhibit the HDACs with this givinostat medicine, we can make more muscle, less fat, and less scar tissue. And the data is actually quite encouraging that individuals on givinostat had less worsened North Star scores. So their North Star scores were higher than those not treated, and that sustained over time. When you look at a picture of the muscle, these are thighs, and you can see the subcutaneous fat around the leg, the bone, and then the muscle. And the muscle should kind of look like a dark, consistent, homogeneous color. And in those not treated, you can see how much more fat's infiltrated within the muscle. Whereas those treated with givinostat, they still had fat within the muscle, but less as compared to the untreated cohort. So I'm summarizing here the current approved therapies that we have in the States. Fundamentally, everyone should be on steroids. There's pros and cons to it. There's all sorts of side effects to steroids, and that's why we have the interdisciplinary clinic that we do. If able, one should be on an exon skipper. If able, someone should receive gene therapy. And anyone and everyone can get this HDAC inhibitor this HDAC inhibitor muscle protection medicine. Briefly, I'm going to talk about some presently ongoing trials and then talk about the future. So first generation versus second generation exon skipping. You can think of the first generation drugs almost as like naked drugs. They're just drugs that are put in. They require once a week infusions. There's not much dystrophin, and they're overall safe side effect profile, but we don't know what long-term is going to show. Second generation conjugates, so it uses e-antibodies or proteins to improve penetration and stability within the body. And because of this, they're dosed once a month, once every 6 weeks, and they can potentially be taken up into muscle better. And that's what's seen. So 2 drugs I'll talk about. First is rosidersen. This is by a company named Dyne that uses an antibody. So the drug itself here is the blue squiggly line, and it's connected to an antibody that targets muscle, heart, and the central nervous system. And thus far has been pretty good. It's an infusion given every 4 weeks. Dystrophin is expressed better than what the first generations, and they have submitted for FDA approval in May of this year. So what we see is that on biopsy samples, the dystrophin expression is markedly higher, 10%, or if you measure it without the fat and scar tissue, nearly 20% higher than baseline. And if you remember back to the first generation exon skippers, it's only like 1% or so. So this is pretty remarkable. The next drug that is really exciting is this drug called Delzota. So this is an exon 44 skipper. And this similarly uses this transferrin receptor antibody to target muscle, to target heart and central nervous system. And it's been really exciting so far. So this is now, it's settled on every 6-week therapy instead of once weekly. And it has significant exon skipping, and CK is markedly reduced. And I'll show some of this data for this. So CK, as you guys appreciate, creatine kinase is often in the tens of thousands. When individuals with this particular mutation have been treated with this drug, the CK essentially normalizes, and that's crazy. That's really never been seen in this population before, so this is really exciting. And with CK stabilization, function is also improving. So the quicker you do these tasks, the better. And so the time to rise, the 4-stair climb, and the 10-meter walk run are all improving. And the North Star score, higher is better, is improving as well. So this is really exciting. Gene therapy, I'll touch on some of the gene therapies that are coming through the pipeline really quickly as well. The two that are most exciting to me are REGENXBIO and Solid, but neither of them are approved, so this data is still early. But for REGENX, all of the data thus far suggests that it is helpful and it improves their ability to stand, to walk, run, to climb stairs, and the North Star is better. So this is exciting. More than just a dystrophin restoration, it seems like it's helping function. Solid is the other gene therapy company that's really exciting, a little bit more early in the pipeline, so they don't have as much data, but what they're showing is histology. And what you can see is in an individual at baseline before gene therapy, they were not making much dystrophin, and then they looked at other proteins that are around the muscle cell membrane. And there's really not that much, but after gene therapy, you can see how much expression of the dystrophin there is, as well as those other proteins. So that's really exciting. This is just another way to look at it. At baseline, there's minimal expression of dystrophin, and you can see how robust it is at 3 months out. And the vector genome copy is just how much of that virus is getting into the muscle. That's really exciting. It's getting in early and it's staying in. A lot of people got excited about this company called Satellos. So Satellos is early, it's phase 1, now 2. And what it is a small molecule to, help regeneration and repair. In DMD, muscle degenerates, it's damaged because of the impairment of the muscle cell membrane, but also its regeneration is impaired because the stem cells require dystrophin to actually, they make this asymmetric stem cell, so it can make more stem cells, and it can also make the muscle progenitors to repair and help the muscle get better after an insult. And so by missing dystrophin, you're degenerating muscle, but also you're impairing regeneration. So Satellos is focusing on that regeneration part. And so by targeting the specific adaptor-associated kinase, it reestablishes the muscle stem cell polarity so that it can make more muscle progenitors and thus repair the muscle. So that's how SAT3247 works. The present studies that have been completed are phase 1, meaning that it was only intended to be done for safety, and it was safe. The phase 1 studies are not intended for function assessment, so any functional presentation of data is preliminary, but overall it's encouraging. So they looked at 20 to 27-year-old men in Australia, and they looked at the hand grip strength. Normal hand grip strength for a 20-year-old guy is about 50 kilograms. And so this was a very impaired population, but it doubled from about 2 to 4 in both the dominant and the non-dominant hand, and the lung function stayed stable. This was enough data to lead to a phase 2 study in America I'm a PI for one of these study sites. And the present study is 7 to 9-year-olds. That is a double-blind placebo-controlled trial looking at a number of biomarkers. It started in earlier this year, so I have no insight to the data, and they're still getting patients activated. The study has completed enrollment, but they're still trying to get everyone to receive the drug because that hasn't happened yet. And then Trailhead is the older population study looking at 16 years and older to just say, in an older population, can we still repair and regenerate the muscle? And so this will be ongoing as kind of an extension of the phase 1 study that happened previously. Another drug that I think is quite promising is this medicine called sevasemten. It's made by a company called Edgewise. And the way to think about this is in muscle, you have some muscle that does ballistic type movements. So like the World Cup, the soccer players that can jump up really high or change direction really quick. Now that type of fast twitch muscle is preferentially injured. And so slow twitch muscle, the marathon runners, that muscle is more protected. And so if one can switch that fast twitch to a slow twitch muscle fiber, you might be able to protect the muscle. And that's how sevasemten works. It protects the muscle from injury by switching to a slow twitch muscle fiber. The data thus far is pretty good, comparable to everything else that we've shown. Muscle changes happen. So muscles are going to get worse with time, but they get less worse with time when taking sevasemten. And stride velocity 95th percentile, what that is our guys wear an ankle bracelet when they go home. And we look at the 95th percentile of how fast they are, how quickly they're moving throughout the day. And that's also better. This is quite well tolerated. I'm not concerned about any safety of this. So I'm flying through this quite quickly because I want to be able to have a conversation on purpose. There are more and more clinical trials every year. And so this brings me a lot of hope for what the future holds. I bring us back to this slide that I showed earlier, talking about treatment classes, the pathophysiologic target, and what we have available presently, but also what's coming. Some of these new trials that are coming through the pipeline. And many times families ask me, what does a cure look like? And I think words really matter. To say cure means that you never have the disease again. And I'm not sure if that's exactly what we're going to achieve. But I think this is going to be not a fatal disease, but I think it's going to be a chronic manageable disease. And the comparisons I make are severalfold. I compare it to HIV/AIDS, which used to be a death sentence, but now people live full lives with it, with medicine on board. Cystic fibrosis, I think, is probably the most appropriate comparison because this is a genetic pediatric disease that used to kill kids, but now individuals live well into adulthood with treatment. Sickle cell hemophilia are quite comparable, that people live nearly full lives with these diseases. Childhood leukemia used to have a dismal survival rate, but now, because of medicine, most people survive this. And I think Duchenne Muscular Dystrophy is going to fall into that same category where it used to be a pretty horrible disease, but I anticipate that people are going to be living well into adulthood. And so I just asked my question, what is this going to look like in 2035, in a decade from now? I think there's going to be gene restoration that's on board. I think there's going to be multiple avenues of muscle protection. I think we're going to have better steroids that have less side effects. I think we're also going to make the muscle stronger. We're going to be able to strengthen the damaged muscle. And what we're already doing, protecting the heart and protecting the lungs, are what we're doing now. I think we'll continue to optimize that. So that's what I think D&D care is going to look like in a decade from now. And I'm going to pose just a couple of questions as my portion of the talk closes before questions of things to consider. People ask about clinical trials all the time, and I think it's important to know exactly what a clinical trial is. So much has to go right, so much has to be figured out to say, is this clinical trial the best thing for our family, for my child? And what actually does a clinical trial mean? There's a concept called therapeutic misconception, and a lot of our families have that. What that is a false and inappropriate understanding that a clinical trial is going to cure one of a disease. Clinical trials don't do that. In essence, clinical trials are potentially helpful, they are not going to be harmful, but clinical trials are not a promise or a guarantee for a cure. It's to potentially helpful, and that's what I hope it does, but it can't guarantee a cure. And I think a lot of families misunderstand that to say that being in a clinical trial is going to cure one's kid. I just try to set expectations appropriate to say that I really hope that it does, but we can't make that promise or that guarantee. And so much goes into it. A child has to be the right fit. They have to have the mutation. They have to meet the inclusion exclusion criteria. What is the goal of the trial? We went through the different concepts, different targets of what therapies are. What are the risks and the side effects? Is this going to be a gene therapy that they can only receive once in their life, or is it a long-term thing? Can it be done in conjunction with what the child is presently and already receiving? How long is it going to last? Is it going to be something that you, excuse me, come to America for a couple of months and then go back to India there afterwards? Or is it going to be something that's going to be longer than that? And then the cost. Trials should be covered by the sponsors, by the companies running them, but that has to be taken care of. And cost is more than just money. It's also missing school, missing work, all of those considerations. And then who is going to be looking after the team? Is it going to be my team and myself? Is it going to be someone else? And then I really tried to harp and set expectations as transparently as possible. And I asked this question, I put this slide specifically for this talk. Should we travel for Duchenne care? There are wonderful doctors throughout the world, oftentimes with different access to therapies, different bandwidths to help families. I think we do a very good job at our center. I think it's a really good team that I get the chance to work with. But I really don't want to falsely say that I can necessarily offer better than what others do, because there are very good teams out there. We and some of my friends in the States have access to clinical trials that might not be available in India. Approved therapies often depend on insurance accessibility. And so while it might be available in the US by prescription, financially, it has to be determined if one can get it. We do have multidisciplinary care at our center, and I think we do that really well with all the specialists that we have. And oftentimes people just want a second opinion, and that's very reasonable. We often work with the local doctors to say, this is what we would do if they're less experienced, and that's fine. I think it's important just to say why one would travel, to say why one wouldn't travel, as if there's no difference in the treatment that one can get back at home versus in the States. If there is intention to participate in a trial, but that's not able to be accomplished, if there's no clear goal. I feel so uncomfortable when people get disappointed with the cost of coming to our center without a clear goal in mind. So I like to be as focused, as targeted as possible. It's hard to get away from school and work, and that shouldn't be minimized. We usually see our patients about once a year, whether within the States or from internationally. But that's hard. And particularly if participating in a trial, we have to have a really close set of communication with our families. And so I think it's important to really ask these questions and to be transparent to say, is it going to be in our benefit to travel for further medical care? This is me about 20 years ago at a muscular dystrophy camp, and this is just about 10 years ago. So I show this to say just how big our group is growing. We work with a number of wonderful families. We have open doors. Glad to help out. And this is our program's contact information that I share, and you can use it to reach out if there's questions, if there's interest in establishing care with us. Feel free to just reach out. And with that, I hope I talked about what DMD is, what some of the standards of care are, and then what I see as the future of DMD in terms of the therapies, but also for families. So I'll leave this here just so people can copy down the email address. But think that's about all that I had to share, and I'm glad to chat, answer questions for the remainder of this presentation. Thank you so much for your guys' participation, and let's have a conversation.
Dr. Steve, thank you very much. Such a comprehensive, detailed presentation. And I think a lot of the questions were, you also kind of covered a lot of the chat questions, what we have gotten till now, including, a lot of folk were asking about therapies. And Satellos was a big question for a lot of people because of the new information they just released. And I think that was the thing. Now, just quickly to ask you this, a lot of chat questions were on exon skipping, a big bulk of exon skipping in terms of a large portion of the deletion. A lot of families have requested. They had some of them have 46 to 60, 55 to 52, 46 to 52. So huge deletions. For these type of huge deletions, do we have any options? Do we have, what are your thoughts on what can we do, and what do you suggest?
Yeah, it's hard. I just put into the chat one of the tools that we use with our genetic counselors. I'm sure, Mohan, you've probably seen this as well. Parent
Yes.
Project Message is one of the American organizations I work and I like with a lot.
Right.
It shouldn't be just the Bible. It shouldn't just be followed blindly. But this Duchenne deletion tool is a good way to assess if one's child is eligible potentially for particular exon skipping therapy. At the present time, the commercial companies are just targeting the most common of exons that could be skipped, and it's not the broad spectrum. I know that there's push to be more inclusive, but at the present time, we're kind of handcuffed by what is available. So I would encourage people to use this exon skipping tool to assess and just ask the question if your child's particular mutation might be amenable to skipping. I think that's how I see it. In the bigger picture, Mohan, I think a lot of these mutation agnostic treatments, the Satellos, Edgewise Sevasemten, Capricor's Deramiocel, Javinostat, I think those incrementally are going to be what are added to the cocktail, the summative therapies that are on board for taking care of this population. It's not a moonshot. It's not going to fix everything at once, but each little addition is going to help everyone.
Yeah, I totally agree. And then you're right, and because there's not one cure all for everything. It's a combination of medicines. And as you had put in very succinctly, the biggest thing is, future wise, we're looking really positive results in multiple drugs. And I think that is an important thing to take away for all of us. I think that is the important takeaway. Now, the other couple of questions a lot of people had was with the adult Duchenne and then their issues with cardiac conditions and pulmonology and pulmonary. Now, is one of the questions was, is it relevant for the fibrosis, how fibrotic your lung tissue is, and does treatment, does it matter what type of treatment you do? And also, do we need to think about any sort of device for cardiac devices? What are your thoughts on that?
Those are good questions. The heart and the lungs are what I worry about very transparently. Those are often what get folks into trouble. We have tremendous cardiac meds, and I think of it not specific for Duchenne, but for general heart failure. And those medicines work really well. We know the earlier that we start them, the better that our guys do. In terms of some of the advanced heart failure stuff, in the States, and I'm speaking specific for us, we're very aggressive to say that ventricular assist device, that even heart transplant, it should be an option for our population. That we're doing a better job at managing this disease. And so even after getting heart transplant, people do quite well and live for a good high quality life after heart transplant for those individuals. So I think it's important to maximize the medication regimen that one can have, but then also it's very reasonable to have the ventricular assist device, the heart transplant there afterwards, if it's the right person, if it's the right population. In terms of the pulmonary care, we get pulmonary function tests on an annual basis. And so we can see we know that the lungs are going to get weak with time. We are big fans of using non-invasive ventilator support. So that's like a BiPAP machine. And to me, a BiPAP, a breathing support is simply just like a wheelchair for the lungs. It's just giving the lungs a rest and a break so that they can stay as strong as long as possible. And it does help. It does help the muscle. And we think of oxygen as important, but more important than oxygen is almost like carbon dioxide. So carbon dioxide is what you breathe out, and too much carbon dioxide gives you headaches. You feel unwell from it, and if you're not breathing it out, it also affects your heart and your heart and your muscle. And so, using a BiPAP when it's the right time is really important to protect the heart and the muscle there afterwards.
Right. No, thank you. And my son uses BiPAP, and I think he does definitely benefit a lot from it. And he feels that he sleeps a lot more better at nighttime compared to when he was not using. And I totally think about that. And again, as you put out, the PPMD had a big, huge conference in Orlando last week, 2 weeks ago, and then we were there. And so they also talked about the cardiology part of it quite a bit, and they had suggested, I'm sure a huge panel of cardiologists were there, and Chuck Villa and everybody was there, and they had suggested as soon as diagnosis was confirmed, they wanted cardiologists to be on board with it, and then on top of it, they were thinking about. They were also talking about starting medicines to protect the heart as early as possible. I'm sure you guys do the same thing too, right?
We definitely do. Yeah.
Now, and again, you had also said about the treatments like Satolos and the new type of medication and stuff. That's fantastic, and I think a lot of the questions have been answered in the chat with that itself. What are your thoughts about physical therapy? What are your thoughts on or occupational therapy and things like that for them? I mean, it is a big deal, and we need to preserve our muscle function as well as our fine motor function as much as we can. What are your thoughts on that?
Yeah, I think the therapists on our team might be the next most important people in seeing our patients. And physical therapy is not one size fits all. Physical therapy is multiple things, whether that's simply just stretching, whether that's doing low resistance, high frequency activities, whether that's aqua therapy. That's a number of things. And so physical therapy can't be minimized. It's the expectation that our population use some kind of ankle braces to keep their ankles as flexible as possible. Physical therapists drive and determine what is an appropriate wheelchair for our population. They help obtain the home equipment standards, shower chairs, toilet seats, all of those sort of things, the Hoyer lifts that our patients need. So physical therapy and occupational therapy is arguably some of the most important people of the team. And with that too, people ask about exercise. Well, exercise is different. I'm planning to do a long run after this talk myself. It's just the morning here in America. And that's an exercise for me, but that's not appropriate for this population. And exercise for a guy who is late ambulatory might simply be standing. And standing in his wheelchair is putting stress on the bones to keep the bones strong, but also keeping the range of motion in his ankles and his legs. And that's a very adequate form of exercise. Exercise is just stretching for some people. And when they get those tight contractions in their hand, stretching their hands is exercise in itself. And I can't say how important and what impact and quality of life that might have for our guys.
Thank you. Thanks again for your input. Now, do you suggest like aquatherapy if you can, or compared to regular land therapy? What are your thoughts?
I think getting in the water is so good for so many reasons. It
Sure.
just removes gravity from the picture.
Gravity.
So these guys that are stuck on land can suddenly move their joints free and really restore that range of motion. It's just nice to get in the water too. So they're getting their range of motion. They're keeping their movements active. Aquatherapy is great if it's a possibility. Yeah.
Good. One other question there, a couple of in the chat is about the mineralocorticoid receptor antagonists, like the spironolactone and the finerenone. Again, now, what are your thoughts on that in terms of starting it early to help the whole function of the heart and things like that?
I'm a big fan of the MRA class of meds. We think of ACE inhibitors, so that's the heart medicines that end in PRIL, lisinopril, as the first class. But we are not uncommonly putting our boys, even before age 10, even before MRIs are obtained of the heart, on like spironolactone or eplerenone, because we know that there is inflammation and there's fibrosis that happens in the heart, and this is the best way to minimize that injury to the heart.
Thank you. Again, I guess it's very big in terms of keeping the heart as much as stable as possible, and that's why we need to do all of that. Now, a couple of other things again before we kind of quickly rule out. One of them is stem cell therapy. I know it's very, very new, and there's a lot of chatter about that. What are your thoughts on stem cells and their kind of big picture?
Absolutely. I see that question, Dr. Sethi. Thanks for asking it. So fundamentally, I think it's important to know what stem cells are. Stem cells are the baby cells that become anything. Anything can be an eyeball, can be muscle, can be cancer. They can become anything. At the present time, the research studies that are doing stem cells, that are literally injecting stem cells, are being done in a thumb muscle and in a foot muscle, and it's like a gram of muscle versus in the thumb and in the foot. That's what's being done at the present time. In muscles, like 20, 30 dependent kilograms of tissue in the body. And so the question that we face right now is, how do you get that single muscle injection to the entirety of the body? I think this is really promising, but we're not there yet. And I'm a little skeptical to say that that's going to be an option in the next couple of years. Stem cells, in theory, sound really good. It sounds really elegant. And to the like Instagram and the TikTok videos, people get excited about it. But I think from the scientific perspective, I'm not really sure that we're quite there yet. So I don't want to put false enthusiasm to something that's not quite ready for the main stage.
Sure. Yeah, that's a big thing too, because how do we deliver all these medicines if you're talking about specific, so it's and that is the whole idea of the AAV and things like that, and trying to figure out how to get these drugs to the entire body. That's what it is. Good. I think we have done, Dr. Stephen. It was a fantastic session again. Really happy to kind of moderate this session. But I don't know if Rama and everybody else at Bharat MD have any other questions, concerns, anything at all. But I think we're coming to kind of really end of our session. Ramaji, do you have any thoughts, concerns, questions, any comments? I hope she's there. All right. No,
sorry, I was unmuted too. I'm sorry, apology. I think my other partner. It was a fantastic one, sir, Dr. Stephen and Dr. Mohan. Yes, there are many, many questions. Many of them have
Sure.
been posting them in our WhatsApp saying, please ask this, please ask that. But many of them have joined. It was overwhelming to see 220 people registering. And 69 are joining now. And many of them are very, very excited to know about the Setilos. The result which has come yesterday, many of them, because many of the people are falling under Axon 8 and 9, which qualifies for the Setilos. On those lines, they have many, many expectations. I'm happy to tell you that few of them have the visa, and I think, as mentioned by Dr. Stephen, they are emailing to the program which is run in their institute. Thank you so much. On the first instance, only Dr. Stephen has agreed, and before 2 months only he has given, yes, I am ready for a webinar for this part of the area, South Asia. Thank you, sir, for that. Dr. Mohan, as always, you have been with us, supporting and encouraging whatever work we are doing with. I should not say we are having limited infrastructure, but as compared to the Western world, the infrastructure and the facilities are a bit not on the other part. That I would like to say. But yes, we are improving. We are trying to get information, details. We are able to get the awareness, education from your part, from the PPMD especially. We recently tied up with Duchenne for the physical therapy, and a few physical therapists who have acquired the course are part of the call now. They are on the call. They have the physical therapist acquired that certification from Duchenne. I'm happy to inform you.
Excellent.
We also run some neuromuscular centers across India. We want to do more. This is information about our organization and about India. I thank both of you for joining us, giving your morning, Saturday morning, which is very to us. Thanks a ton. And we would like to have more sessions like this. I should say, like Dr. Stephen, it's a very, very informative session and very hopeful. Very hopeful. Thank you. Thank you so much, sir. Both of you, thanks a ton.
No,
It's
no,
a privilege.
I think,
you guys.
yeah.
Yeah.
Go ahead, Steve.
Sorry.
Go ahead. No. Go ahead, Steve. No.
I just say it's a real privilege. I look forward to working with you guys more in the future, and do reach out if there's any questions. I put our email and our team's website in the chat for everyone.
Yeah.
Thank you.
And again, thank you for everybody. Thanks again. It was Ramaji. It is fantastic. I tell you again, you guys are doing a fantastic and phenomenal job, and trying to get everybody on board. And again, a pleasure for us to work with you guys. And you let me know if we can do anything else. As much as we can do from here, we will try to do that. And I'm happy that my alma mater is one of the first at Duchenne Clinic. So it's fantastic.
Thank you so much.
Right.
Thank you.
Okay. All right. Bye, everybody. Take care then. Bye, Steve.
Bye-bye.
Bye-bye.
Yeah.
Okay.
Thank you. Bye-bye.
ఏరా మాట్లాడి చెప్తున్నా నన్ను